Now I would request Professor RAGINI PAREKH to give her next talk. Professor Lahane and Professor RAGINI are famous not just for doing very high volume cataract surgeries, small incision and phaco, but also for doing a lot of training that happens in the meetings, whether it is BOA, whether it is AIOS. And in fact, this instruction course has been going on continuously for the last 14 years. And thanks to all the delegates, we've always had it in full halls. SICS, we all know, is a wonderful surgery, and as Sir was saying, it still accounts for the majority of the cataract surgery that is done in this country. And it's not just a fallback surgery or a surgery for the poor, it's a surgery of choice for so many things. So here now ma'am will be speaking on SICS and surface disease, how to tackle it.
Thank you, Dr. Parikshit Bhai, for the lovely words. And when you were not there, I was just telling everyone about the lovely scientific program that you have made great efforts to make, and you being a part of the scientific committee of the AIOS. Thank you for your kind words. So this is another topic that we don't take very seriously. That is SICS and surface disease. So we will be I work at Grant Government Medical College, and the financial disclosure that I have is that Sir always asks the trade for drops for the patients or money for the conferences. Now if you see a patient over here, what happens if you see the lids, carefully observe the lids, and what will happen if we operate this patient. This is the magnified image. As you can see, the meibomian gland and the secretion. So what happens if we operate the patient? You can see the waxy congealed meibum, and you miss this. Okay? So what happens is that what will be the sequelae of this? The patient will complain of foreign body sensation, pain, watering, and the thing is that the patient will be 6/6 but not 6/6. So that is the worst part of it. That you keep on thinking, arey, this patient is 6/6, and he keeps cribbing, and you will be really upset with the patient because the patient definitely is unhappy, but you will be very stressed out and frustrated because the patient can read 6/6. Now what is the definition? In 1995, the definition and classification of dry eyes was that it is a disorder of the tear film due to tear deficiency or extensive tear evaporation which causes damage to the interperipheral ocular surface. And it is associated with ocular discomfort. Then it again changed that it is a multifactorial disease of the tears and ocular surface which results in discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. And it is accompanied by the changes in osmolality. It further changed that it is a multifactorial disease with a lot of loss of homeostasis of the tear film, ocular symptoms which is accompanying them, instability of the tear film, hyperosmolarity, ocular surface inflammation. So as you can see, the definition keeps changing. And when the definition keeps changing, it means that we do not know the disease completely. I just came across a book which is so thick only about the tear film. So we don't take it seriously, or we concentrate only on cataracts. And something that we don't understand completely can cause a lot of trouble to us. So if you miss the diagnosis of dry eye preoperatively, as you can see over here, what happens to the effect of dry eye? Intraoperative, so dry eyes, there may be a misdiagnosis. There may be an intraoperative increased surgical time, incision size, lens hardness. This also affects. There will be inflammation because of the intraoperative problems, and there will be a reduction in the goblet cells. Post-operatively, we give a lot of eye drops, and there are preservatives in the eye drops. And some patients are very happy when you tell them to put drops. They think that by putting more drops it will help, and they keep on putting lots of drops in the eye. So all this can aggravate the dry eyes or cause dry eyes. As you can see, when you stain the tear film, this is how it looks. The patient has a red eye. And what would you like to do? Pre-operatively, you do a Schirmer's test, you do the fluorescence staining, you do a T-butt, and you do a meibography. Now, normally we don't do all these in our cataract patients. We have a standard format for workup, and we work up the patients. And it is not necessary that you do it in all the patients. But in a patient whom you are seeing on slit lamp and you suspect having a disease, then there is no harm, or actually all these should be done. If you see this case, there is a patient who has a 45-year-old male who has a corneal opacity with a PHC cataract. Now there is a parapupillary corneal opacity and a cataract. It is disabling to the patient. You go ahead and do the cataract surgery. We do this so often and it is done every day. Now this is what happened to the patient 7 days after cataract surgery. As you can see, this patient came with a large epithelial defect with infiltrate. The cataract surgery has gone very well and the patient is happy. You have given reasonable results. And why this occurred? So, and this is so disturbing to the surgeon and the patient. So, as you can see over here, what went wrong? So, this healed, but it healed with a larger opacity. The patient was not satisfied. It has now covered the pupillary area. The patient is upset, and you know what happens when the patient becomes upset. Now, what went wrong was that this patient actually must have had old herpes keratitis. Now, sometimes the patient does not give a proper history, or we may have not asked a proper history, and because of the post-operative steroids, the herpetic condition got aggravated, reactivated, and the patient had an epithelial defect. So to correctly get a history, to check the corneal sensations, to find out what happened when the patient had a corneal opacity, and you have to be very, very careful before doing any surgery. The eye has to be quiet, and you have to examine the patient very well on slit lamp with a magnified view, looking for superficial or ghost vessels, and reactivation of the keratitis in case of fever or stress that would have given an indication. Even then, this could have been missed. And so one has to be very careful, and the case is just to say that the ocular surface, which is a very neglected part, needs to be given a proper attention. As you can see over here, this is a mimosa plant which is very, very delicate. So systemic diseases which affect the ocular surface, which like rheumatoid arthritis, the pre-operative factors, the post-operative factors, and the surgical factors all will influence. Systemic diseases like autoimmune disease, rheumatoid arthritis, Sjogren's syndrome. Surgical factors like the incision, additional incisions and the time taken for surgery. Irrigation of the ocular surface. So many a times, like we are in a medical college, the patient is going to be operated under topical anesthesia. You are taping the eye, the patient is sitting outside, and when the patient comes in, the corneal surface is dry. So irrigating the corneal surface, putting viscoelastic on the corneal surface when you are operating, how much concentration of betadine you are using to give the betadine wash. These factors are very, very important, because if the patient has a corneal epithelial defect the next day, you have to put steroids. And if you don't put steroids, the cataract surgery post-op will be affected. If you put steroids, the defect will be a problem. So ocular surface has to be really, really taken into mind. Preoperative factors means examination of the tear film. We may not be specialists in that, but we can find out that what is the change in corneal sensitivity and the ocular surface anatomy. So all these factors are very, very important. We give an array of drops. We give lots of drops. I know a patient with rheumatoid arthritis who was given topical NSAIDs many years back and came to us with corneal melting. From that day, even for retinal problems, I'm so scared to give NSAIDs, and we never give it unless without the cover of artificial tears. And we have seen corneal melting. Self-medication, as we all know, it is the biggest headache in our lives, and aggravation of the previous dry eyes is very, very important. So refractive surgery, contact lens wear, topical anesthesia, low lacrimal flow, tear hyperosmolality, these are all factors that we have not paid attention to. And after that is that what will we use? These are different types of artificial tears available, and you have to choose each one depending on what type of tear deficiency the patient has. This is not very difficult or complicated, but once you start paying attention to it, it will be helpful. Now you see so many children and young adults who've had vernal keratoconjunctivitis. You start steroid drops for a short period and pulse dose, but the patient is so happy with steroids that without visiting the doctors, we've had patient coming back after 2 years with cataract and glaucoma because they were so happy with the condition that remains stable because of steroids. And this you see very, very common, limbitis, papillae, inflammation. So in these cases, it should be performed only in a quiet eye. You should be aware of topical and systemic immunomodulators, and it's not necessary that you should be the master of all diseases. We have friends who are specialists whose help can be taken. For example, Dr. Sumit Lane is our cornea specialist. My father has Sjogren syndrome and I was treating him, but his eye became more and more red. I thought that he had discharge. I started moxifloxacin. It became worse. He had scleral thinning. And one day Sumit stopped everything, started gentle gel, and my father's problems were solved. So it's important to take the help of a person who is really specialized in the cornea care. And there's no harm because if you are a cataract surgeon, you are not going to see lots of cases of cornea. And you have to decide what is the duration of all these drugs that you are giving. Secondary glaucoma because of the vernal keratoconjunctivitis induced steroid glaucoma should also be addressed. Stevens-Johnson syndrome, ocular cicatricial pemphigoid are all seen and they destroy mucin, aqueous layers, meibomian glands. These are really complicated patients which need a lot of care because of all these problems of keratinization, punctal scarring, symblepharon that the patient has, trichiasis. And I have seen in North India when I was operating in Allahabad, you see a lot of patients with sequelae of trachoma even today. So you have to be very, very careful. So recommendations are that you have to manage the dry eye, you have to reconstruct the ocular surface, you have to replace the limbal stem cells, dry eye therapy and conjunctival treatment. So it is better to avoid SICS in difficult and complicated cases with xerosis. The conclusion is that you have to be very, very careful. You have to keep dry eyes in mind, not to have post-operative problems. Ocular surface disorder needs a holistic approach. Cataract surgery should be customized for every patient. Pre-operative counseling of the patient will prevent a lot of post-operative headache, and follow-up and use of modulation is important. Thank you so much. I just wanted to highlight that there may be other factors than cataract surgery and ocular surface or dry eyes that need to be addressed during the cataract surgery. Thank you so much, friends.
I thank you, Ragini. Thank you very much. It was an excellent eye-opener. So whenever you are doing the cataract surgery, so you should not just make an hurry, but you must examine patient thoroughly so that post-operatively patient will not